9th. I call this meeting to order. Prior to our first action is I need a motion that the items on the meeting agenda constitute essential business of this board. Meeting electronically is necessary to protect the health, safety, and welfare of Tennesseans in light of COVID-19 outbreak. And any board rule that conflicts with the Governor's Executive Order 16 permitting electronic meetings be suspended. Is there a motion for that?
So moved.
So moved.
All right. Thank you. So Ms. Essington and Vice Chair Franklin seconded. Any discussion around that? All in favor? All right, I see hands for everyone. So that's 4-4. Right? Any opposed? No. All right, thank you. That carries. There are meetings minutes from June 11th as well as June 26th. I would appreciate review and possibly a motion for approval of these.
I have one thing on June 11th.
Yeah, June 11th.
On page 6, I did not vote for the first motion. It says I did. I abstained. On the second one, I did vote for.
All right. Martha, you catch that? Oh, Martha's right there. Sorry. Martha's sitting over on this side of the room. Okay. Any other corrections or edits of either of those? Hearing none with the edit of that Carol proposed, is there a motion for approval of these minutes?
So moved.
A move. Is there a second?
Second.
Second.
All right. So Dr. Campbell, Mr. Frederick, all in favor, raise your hand. Okay, that's unanimous. Thank you. All righty. There is a letter that circulated a few minutes ago thanking Dr. Johnson for her years of service on the board. Anyone have any comments around that letter?
Thanks to Martha for her draft.
Yeah, thank you, Martha, for the draft. There's no discussion. We would have to vote to approve it prior to us signing. So anyone make a motion to approve?
So moved.
All right, Mr. Frederick, and a second by anyone? Ms. Franklin, second. All in favor, raise your hand. Great. Ms. Franklin, are you voting yes or no? I didn't see your hand.
Yes, I'm voting yes.
You. I figured thank you. All right, that carries, so we'll sign that. I am very, really pleased and honored to have Amy Richardson here with us. Are you there, Amy? Are you still there? I don't see you anymore.
She was.
Oh, did we lose her? Hey, excuse me. Is Amy Richardson on still with Salome? Well, okay. We will come back to Amy. Okay. Do you have her number by any chance, Carol?
I do.
Can you text her and see if she's coming back on? Okay, we'll come back. One thing real quick is...
I'm logging out and back in.
There she is. I just see her popping on. Okay. Amy, good to see you again. It is your show. So first of all, I just want to say thank you to you and Salome for everything you've done. Anything you are doing, both now and previously. And I know we all look forward to hearing your presentation. So the floor is yours.
Great. Sorry, I somehow lost internet there for a second. So glad to be back and glad to be here. Thank you so much for the invitation to share with you all. So for those of you who may not be familiar with Salome, I'll just start out and introduce ourselves to you all. So Salome is a faith-based, charitably funded nonprofit organization in Nashville that provides whole person care to the un- and underinsured in Middle Tennessee. We're almost 30 years old, but we're still fairly small. We serve about 4,000 patients a year, and about 90% of those are refugee and immigrant population, speaking more than 80 different languages and coming from 70 countries. So we have a really diverse patient population. In addition to that, we have
There's Carol. There's Carol. Hold on, I got you. Hold on. I know you're muted, but now you're volume. All right, we're in business again, Amy. Sorry, please.
Great. So, in addition to our 30-year history, we have recently opened our second physical location in Antioch. So we just opened that clinic a couple of weeks ago, which is pretty fortuitous considering the COVID concerns that are in that part of the city right now. So we now have two physical locations for our primary care services. Another aspect of our work is our community health programs, which is the part that I lead. And I think part of what brought us to connect to Metro Health in the middle of the COVID situation, because we have a strong community health worker program. So if you're not familiar with community health workers, I want to take just a minute to explain who they are. So community health workers are lay people who are members of the communities that they represent. They're the kind of people that aren't necessarily medically trained, but just are innately empathetic and share a common background with at-risk or populations in need. And so at Siloam, our community health workers come from refugee and immigrant communities. They share languages, common language with the populations that they're serving. And when we connected with Metro Health, it was wanting to do so over this dedicated model of a community health worker program, because we see it as a really effective tool in reaching out in the midst of this pandemic. So community health workers are able to help with underlying challenges that impact health outcomes. So they're really working on issues that are social determinants of health, things like food insecurity, social isolation, housing instability. And it's this shared life experience that literature shows makes them more effective at providing care than some of the other strategies that we sometimes see trying to use med students or even nurses or doctors sometimes, because there is a large amount of trust with community health workers. So in our work with Metro, I shared with the board, I hope, a kind of a one-page sheet to give you some background so I wouldn't have to go into quite as much information about what the program looks like. And instead, I'll focus more on just how the program is going. So the program itself is up and operating. We've seen some great successes in that we know that community health workers have evidence for a strong evidence base across the country in COVID response. And we had this model up and ready to go, already working at Siloam and in these target communities where we're seeing COVID hit very hard. So Siloam already had the rigorous training and the infrastructure ready. And so with that, we were able to hire and onboard quickly through Metro hires, but we ran the process of that interviews and whatnot to hire 6 part-time community health workers and a coordinator to help manage the program for COVID response. And then we were able to do a really intense training. Normally we spend about 80 hours in training for our community health workers. We still were able to get about 20 hours of training in and deploying them within a couple of weeks. So we're really proud of having this ready to go. In addition to that, we worked with other community partners. So we co-trained navigators at the Tennessee Immigrant and Refugee Rights Coalition, or TIRC, and we're able to help them get out and also share in the work of reaching out to these hard-hit populations. We've also started sort of an interagency working group for other nonprofit partners who are reaching out to these populations so that each agency can focus on our strengths and work to make sure that the populations are being supported in the way that is needed. The community health workers have also been able to participate in some wider community education opportunities. So the Spanish language press conference from the mayor's office with Fabian Bedne, we've had one of our community health workers there. we've had some of the Arabic speaking community health workers live stream on one of the Coptic church Facebook live streams that had over 1,000 views. So they're really able, they know the networks that their communities respond to, and they're reaching out to those communities. And so we think that these are already trusted members of the community and are able to effectively message important information in this pandemic season. So just a few highlights, I think, of things that are working well. Some examples of what our community health workers have done is that one of our community health workers was paired with a case who had been diagnosed with COVID, but the man was homeless and had not eaten in 5 days. He lost his job because of COVID. And then been unable to pay for rent or get connected to food resources. And so he had this diagnosis, but didn't have a way really to care for himself. And so with her support, he was able to find housing. Through the housing situation, they helped find him a job. And of course, he was able to be connected to food. So that's maybe an extreme example, but one that I think illustrates well how it would have been hard for this person to maintain isolation had he not had the resources that the community health worker helped connect him to. Another story is one of the community health workers helped connect a patient whose employer had violated HIPAA with her COVID positive status and shared it with the company. And so the CHW was able to connect this patient to legal support so that they can navigate that process after the diagnosis ends. We see a lot of community health workers connecting patients to PCPs, which we're thankful, whether they're uninsured or insured, some of the population wasn't accessing healthcare. And so we know that through this connection, the relationships that they develop with the primary care providers will last far beyond the pandemic, we hope. And so this is a tool that we see having ripple effects, even though community health workers are only working with the COVID positive patients for a few weeks at a time. We also see some opportunities that still exist. Definitely still see needs in the community and needs even within the systems to improve. So one of the opportunities where we see room to grow is in the data quality and data flow. We see that at multiple levels. So even starting at test sites, making sure that data is collected accurately, names are spelled correctly, and contact information gathered correctly, because those opportunities delay the connection of people of finding out their test results and isolating and quarantining appropriately. And then even within information flowing through the labs and to the investigators at the health department and some of the internal reporting systems at the health department, we've been sharing feedback about ways that we see to improve that process. Because right now the community health workers aren't working at their full capacity. So we've got room for them to grow, and we know that it's an effective model. I also want to take the time to highlight an opportunity to make sure we're collecting real data, race, ethnicity, and language data. Not only does this help connect community health workers to the appropriate populations of need, but I think it also helps us just in the larger picture of disparities that we're seeing across the country right now, of making sure that people receive equitable care. And if we're not sure who we're serving, then we don't know how to best provide that equitable care. So making sure that we are collecting that data and reporting that data accurately. Another opportunity, I think, is to really work to address some of the root causes. So we're seeing lots of strategies being made to flatten the curve, but over and over again through the work with the community health workers, some of the root cause we're seeing is around economic incentives. People needing to go to work or needing to have money to provide for their basic needs. And so an opportunity to continue flattening the curve would include issuing and following through on clear workplace health and safety regulations, holding employers accountable for that, instituting hazard pay, providing information to workers about their rights. Because again and again, that's what we hear the most from the patients that community health workers are working with, and even from their own communities, people who aren't COVID positive yet, but just in their own communities, is a real need to address workforce issues. And then the last opportunity that I think we have to promote is just to continue to promote policies that build trust. So I know it's a common knowledge that perception is one of the biggest areas of importance in public health response, in a crisis response, and the perception of the immigrant community of how we're responding is an important way, again, to help flatten the curve. We're seeing fear within these communities, but I think an important part, nuance to note, is that there are different kinds of fear. So some are distrustful of how the government might use information that is collected. Other maybe fear because they don't know what happens when you pull up to a test site, or how to access services, or how to pay for the bills that they may encounter if they are hospitalized. Fear of employer repercussions is a large part. So if I get tested and I end up positive, then I can't go to work, and I don't know how to manage with that. So different kinds of fear, but fear is definitely there. And so important policies around the data sharing and how to get information to test sites. There are lots of levels where I think the leadership of our city can lead on building trust. And I want to use a patient story to highlight that. So we've had one of our community health workers working with a patient who felt very distrustful of the system. The system she didn't define. I think it could be kind of just her interaction with American healthcare and public health and government all together. But she wasn't sure what to do. And so she wasn't even sure she wanted to talk to this community health worker at first. She was, a government employee. And so having that shared language and having a common background, this community health worker shared her own story of immigration to the United States and allowed the patient to open up and talk about her experience, what had gone well at the test sites, at the hospital, because her husband had been hospitalized with COVID, and then connecting her into health beyond the COVID diagnosis. And so I think it's really important as we think about not only the COVID response, but what we hope to see in the future with vaccine uptake. So building these trusted relationships now so that in the future, as health continues and as we continue to build relationships with immigrant and refugee community members, that we can take advantage of that through programs like the community health workers. So I'm going to stop there and allow you guys to ask questions. We'd love to respond, whether it's about our partnership with Metro or with Siloam itself.
Thank you so much, Amy. I open the floor to questions. I really, the work you guys, I can't overstate the impact that I know it has and will continue having, and amplify so much more and get our response, especially in those important communities, much better than where we had been. So thank you. I open the floor up to questions or comments. Anyone? Sinead?
Yeah. Thank you, Amy, for coming to share this with us. Couple of questions. You said that there are 6 part-time community health workers and navigators, and then I think I heard you say that they're not operating at full capacity. Mm-hmm. I also heard you outline different examples of feedback that were given to the health department on how to improve processes. So I'm wondering if you could just speak to why only 6, because I know that community health workers are used as a strategy to advance health equity, and other municipalities are being used robustly. So why only 6? Why aren't they being used to capacity, particularly if there's a lot of feedback given to the health department on how things can be done better? And then lastly, if you can tie in how contact tracers are working with community health workers, or if there's any discussion in community health workers serving in that contact tracing role.
Sure.
A lot, I know, but You can do it.
So we started with 6 because that's what Metro asked us to start with. And so they had identified languages that we hired for. So we started with that, and I do think there could definitely be opportunities to multiply the workforce. But making sure that we are operating at capacity should be happening first before we're adding new hires. The capacity issue, I think, again, I touched on some with the data flow. So the system of connecting COVID positive individuals to the community health workers, we're working on a number of iterations of how that's happening. It's supposed to happen, the investigators should be referring those, but that wasn't happening in large quantities. So we added a community-based referral line, and just this week, the health department, I think, has added Turk as a partner to help message that more broadly to the community, because some of the channels that I don't think that referral line information was getting out there broadly enough. And like I said, our CHWs themselves have been doing a lot of messaging through their own channels, but this has been more of us responding to the lack of referrals that we've been getting from within the health department. So I am eager. I shared with them some additional new strategies just this week of ways that we might increase that referral and process. And then if we see that happening, I definitely see a role for community health workers to continue to be added to the workforce. In terms of the contact tracers, in Metro, community health workers are not working as contact tracers per se. There are differing opinions for those using community health workers as to whether or not that's the best strategy. For me, the biggest priority is that community health workers remain a source of trust. And so if the community sees them as a trusting resource, then I think that they could be used as contact tracers. If they're seen as just gatherers of information, then that can break trust if they're worried about how that information is going to be used. But they are being used effectively in other parts of the country, some. So right now our CHWs are working separately than the contact tracers at Metro. But we were just talking this week about the potential of maybe having them call in tandem to see if that increases uptake some. So we're trying different strategies, again, just with trust being the bottom line.
All right. Thank you.
Thank you.
So when you say you had shared some new strategies, there's a two-pronged question. With whom are you sharing those strategies? I don't know if you're talking about Metro Health or someplace else. And in general, how do you perceive the overall coordination and cooperation between and among these different agencies and or groups?
Yeah. So this week I shared with Leslie Waller. She's been the lead person for me, and to me, I've seen her doing a lot for, she's wearing a lot of hats, and so it's hard for anyone to wear a lot of hats, I think, but she's been responding as well as I think someone wearing a lot of hats can be responding in this season. So I'm thankful for her partnership. The health department has recently added an additional person in that role. I'm sorry, I can't remember her title, but she's focusing on the immigrant outreach. And her name is Harriet. And so I shared it with Leslie and Harriet this week. In terms of our partnership, so we have a great community of nonprofits. Turk and Conexion and Salam, as well as some others, have worked well together anyways. But I would say particularly in this season of COVID response, we all see the populations that we serve regularly in need and hurting. And so we've been able to work together. So I'm glad to see the health department now this week bringing us together in the formal partnership with the health department through, I think I don't know all the details of it. I only know one side of it, but there are bringing Conexion into some of the resource distribution picture with the health department and Turk with the communications. And so I think there's opportunity for us as nonprofits to bring our strengths into the health department together.
Okay.
So the follow-up would be for perhaps somebody sitting in the room, whether Dr. Caldwell or if Leslie, you're there, or whomever else, to just enlighten us the next step and cite what you're seeing as some of the challenges and or how you see really increasing and improving the coordination and the delivery of service with the CHWs as well as with the other organizations.
Our caller, Leslie, or whomever may be available to answer that.
This is Dr. Wright. Challenges, we are seeing challenges. I mean, working to build this trust, build the relationship with all of these different organizations within the community that have good insight, very important, and we continue to do that. We are working to increase our testing and our outreach within the communities through these organizations. And it's a learning curve for all of us, and we're continuing to learn and grow, and we want to partner and make this successful for the community.
All right.
Who was that was talking?
That's Dr. Wright. It's Dr. Wright.
Oh, okay. I didn't recognize your voice. Thank you, Dr. Wright.
Yep.
All right. Thank you. Any other discussion? Move on. Amy, again, I can't overstate it. I'm grateful to you and all your colleagues. Please know everyone on this call and this department will do whatever we need to make this relationship strong and successful, because I think this really matters that we do this well. So thank you.
Thank you very much.
All right.
Thanks, Amy.
You know, now I want to talk really quickly about our special meeting a week or two ago around the board policy that specifies that we felt that wearing a mask is critical in saving lives. And I want to just say to the board, our decision, I feel, as a policy is a right one. In fact, IHME from University of Washington does the modeling. It just came out. It's a great, their new website that you can actually follow, and shows that mortality will go down 22% if mask wearing becomes widespread across our state. So I just tell you all that to say, I know we've all had some time to think about the policy. Dr. Caldwell signed it a week ago. I think we'll start seeing impact of this policy hopefully soon. And I just, as a board, would like us to ratify the fact that we believe this is still a good policy, and like to just reconfirm our vote. So that's kind of what I'm asking for. So is there be any support of just saying we support the policy that we voted on last time, as we've all had some time to think through it, or anyone we can comment. So.
Well, I would say that I do think that it will make a difference. I think it is already making a difference just being out, whether it be at the supermarket, Walmart, Home Depot, these places. I have noticed that the vast majority of people are now wearing masks as opposed to before this order went into place, and I think that we should continue.
Great. Thank you. Anyone else?
I agree.
Thank you. So would somebody be willing to make a motion to just reconfirm our policy that we all made?
I'll make a motion that we reconfirm the policy that we made.
Thank you. A second?
I would second that motion.
Thank you, David. Any further discussion around this? All right, hearing none. All in favor of reconfirming the policy, I think, is superb. Raise your hand. That was very much biasing my. All right, thank you. So that seems unanimous. Thank you. Motion carries. All right, as we do every month in our commitment to our city leaders, every month we'll evaluate the Declaration of Public Health Emergency. As you recall, this is a declaration we signed in March, or we agreed to and approved in March, which allows the authorities of Dr. Caldwell to do things such as the mask order, the spacing orders, all the other orders that falls under the public health emergency. As every month, as you all recall, we discuss this, evaluate this, and see if we want to extend this for another month. The governor, as you may know, recently extended his public health emergency order. And so I would welcome any discussion or a motion to extend this for another month or more, but I think a month to me. I like the idea of a month to month personally. That's my bias, but I'm not making any motions here. So any discussion around
I'm very supportive of this, of extending it for an additional month. I do think that I would like to see us tighten up our communication so that the members of the Board of Health are aware of the orders as they are developing, because we do get questions and people hear rumors. How they hear them, I don't know, but we get questions as things are developing, and it would be good if we could. I don't have to be involved in the development of it, but just be aware that it's happening, so that when I get questions, I can address those questions.
Thank you. That's really great feedback. I will, as chair, as I hear them, I will make sure I can communicate with you guys directly. I'll make sure that through Martha, and Dr. Caldwell, who I know is on the call, will do a better job of that. That's a really good point. Thank you. All right.
And given that, I would support advancing this. I'm not sure what our next board meeting date is, but I would certainly want it to extend past that date. So should we extend it to August the 30th? Would that be I will make a motion that we extend it through August 30th.
Yes, sir. And that is in line with where we are now, because this one currently expires at the end of July. So extend it till the end of August. Is there a second for that? Carol, second.
I have a question.
Yeah, of course. Discussion point. The motion and second has been made, and go ahead, Ms. Franklin.
Okay. How if we are only extending it to the end of August, how does that impact the decision that's being made regarding MNPS schools? How are we thinking about how both of those decisions are in sync or complementary of each other?
From my perspective, I think that what I heard today on the 1 o'clock conference, press briefing, whatever you want to call it, is that Metro is looking to reevaluate this somewhere around the 1st of September, whether it's literally the 1st of September or not, and we would be meeting the 2nd week of August, so we would have some idea where their thinking is, and we would have a chance to revisit this in August. That's where my thinking is on that tonight.
I think that's right. I also would say that I don't believe Metro Schools' decision is dependent per se legally on our decision to extend a public health emergency or not. I believe Metro Schools can make their decision independent. Obviously, they're very much in line and very much in communication with this department. But before, of course, I think just purely, and I hate to use the word legally, Derek, so please correct me if I'm wrong, but I don't think the two are tied directly. Obviously, there's a lot of input or thoughts about what the city is doing and what Metropolitan Schools are doing, but I don't think the two legally are connected. But to your point, David, we would meet August 13th, I believe, and would allow us to extend this to the end of September if needed, if that's how we go.
Dr. Hunger, you expressed yourself adequately.
Okay, thank you. Okay, so there's a motion and a second. Any more discussion? So everyone in favor of extending this till the end of August, please raise your hand. Okay, that's unanimous. Great, thank you. And Dr. Campbell, so the deliberation data sharing policy, if you all remember at our previous board meeting, there was a discussion around the, what's called the data sharing policy, protocols that had been placed for this group, or excuse me, the protocols that have been placed to share COVID data with the police specifically at that point. At that point, we voted to stop that and put together a committee, which we did, that Dr. Campbell chaired, to discuss if there was a way to move forward to recognizing all the important interests and concerns that people had. Dr. Campbell chaired that group, and I will defer to you and or your designee to brief this group as to what your outcomes were and if any action needs to happen. Dr. Campbell.
Okay. Actually, I think this is an action item. The task, as I understood it, was that Mr. Durbin needed a policy statement from the board before he went to get the actual technological setup completed through Motorola. And he needed us to be clear about that. We had 2 meetings with representatives from the community. We had Dr. Farmer Dixon, Keith Durbin, Jill Fitchard, Melody Fowler, Chief Swan, Dr. Caldwell, and Angie Goins, as well as myself. We met twice, a lot of discussion back and forth about how to balance things, and we kind of came up, we finally came to a what seemed to be a consensus, and I came up with a draft proposal to be submitted to Keith Durbin to represent the policy of the board about this. And let me read it to you. It's in your packet. Tasked with obtaining stakeholder input for a Board of Health policy, we've come up with this tentative proposal. COVID-19 test result information is privileged information to be used only by the health department in carrying out its primary task of providing optimal health care for the community. This information may be shared in a limited way in the following circumstances. A, first responders to a medical emergency, 911 calls. B, law enforcement only if vehicular transport is involved to the jail or the ER. When technologically possible, this information will be stored on a private server in the Department of Health. D, there will be auditing by an independent committee, including community stakeholders, to assess how it is being used once it's established and set up. E, it's important that all Metro employees interacting with the public use the best PPE practically available in these situations. This was consensus at the last minute. I sent this draft out to all the participants for further comments or editing. There were none. I assume this represents the consensus of the group, and I'd like to work for approval as our proposal.
Thank you. So,
Dr. Jahangir?
Is that, yes, who is that? Tom, yes, sir.
This is Tom. Dr. Campbell, I looked over that earlier today, and it's the phrase when vehicular transport is involved, and then it has in parentheses jail and ER. Was that meant to be limited to that? Because they do take them to the mental health co-op as well.
Well, that's a good point. I had meant to put, for example.
Okay.
Okay. Okay. So your motion, Dr. Campbell, is for the board to accept this. Is that a correct summation?
Yes.
Okay. Would there be a second to this before discussion or discussion and then a second? I'm happy to go either way or both ways.
I have a question, so I guess discussion first.
Yes, of course.
When you say when possible, we would house this on a secure Metro Health Department server, what is the proposal that happens in the meantime? Because my understanding when we had Mr. Durbin on a call we had a month or so ago.
By the way. Mr. Durbin's on.
Good. That this might take months, at least weeks, if not months, to accomplish. And so that leaves a pretty large gap in time before we're able to perhaps place it on a more secure server that can then be queried by, I'm assuming, the 911 operator per the last conversation. So I guess I might ask that question of Mr. Durbin.
Sure. Hey, this is Keith Durbin, Metro ITS. So that data, as I understand it, is already on secure health department servers. So there would be no change in the time between we present the specifications to the vendor and then getting something actually in place. So that wouldn't change. We may alter, we may change the configuration of the server. We may do something to make it easier to access, but it would still remain in health department operational hands.
So with it remaining within the health department secure servers, does that mean the 911 operator would not have access when the health department is not open? Because it seems as though previously we were giving some sort of a list or a data dump or some sort of information to emergency response so that they could query that as opposed to querying our database.
So I'll just respond. That all stopped when this body stopped the sharing of that data. So there is no transfer of lists back and forth at this time.
Okay, so between now and the time that we can give the emergency responders access to our database to query against it in some sort of fashion, which as I understand is what Motorola is working on, how would they access the database, say at midnight? Would they have any way of knowing that right now?
The situation remains the same. This body stopped that querying, and that it will not kick back in, barring some other action of this body until those solutions are in place.
Okay.
So I have a few questions, but just to follow up on that one particular point that David made, I was wondering if Dr. Caldwell can speak to, I believe Dr. Caldwell was part of this group that was convening. Dr. Caldwell, could you speak to the plan that if the board approves this today, that the data on the health servers will be able to be accessed? What are some thoughts going around on how that could happen?
Well, if the Board of Health approves this plan, that policy directive would go to Mr. Durbin to then discuss with Motorola, and then they would proceed to provide us feedback on how long that would take. And then we will report back to you on that information that we get back from the contractor. At this time, when the board decided to stop the sharing on June 12th, there's been no information shared with anybody until this policy was determined and until such a time as this new process is put in place.
Okay, let me ask it a different way.
Still not quite a precise. I'm sorry. Go ahead.
No, I was going to ask, when this body convened, did you discuss how the data may be shared off the health servers in the interim until Motorola we were able to execute Motorola? So what is that interim plan for being able to share data off our health servers? What does that look like?
Sure. There is no interim plan. And we brought this up at the board meeting when the board voted to suspend this. There would be no interim plan. There was no other interim plan other than what I had suggested. It was that we continue doing what we were doing. So that was the interim plan, but the board suspended that and offered no other suggestion on any other interim plan. And we don't have the capacity to have any other way to do it unless Mr. Durbin has some other thought on how to do it differently than we were doing it on an interim. But the way we were doing it was working.
So hold on one second. Can I ask you a quick question, Dr. Caldwell? I'm sorry. Mr. Durbin, why don't we maybe one point of clarification here from Mr. Durbin is if the board approves this now, what's the timeline to get a secure system that's compliant with this in place? And then maybe we can have it. Would that maybe help we get some clarity around that?
Yes.
Sure. This is Keith again. So there are actually two components of this. One component is actually the Motorola component, which is the 911 component. That is the activity where there has been a technology working group that has met multiple times that has defined some specification work that as soon as this meeting is over, or actually as soon as you all decide which way you're going to take this policy, We will meet again tomorrow. We've got roughed in kind of what our specification is as of Monday of this week. We will meet again tomorrow, and then the representatives from DEC, Steve Martini and his team, will get that over to Motorola. Motorola then, it is incumbent upon them to, after review of that and after a back and forth discussion, will bring back a quote in terms of time and money as what those changes would take. And based on prior experience of Steve Martini, the DEC staff, typically when a request along these lines goes to Motorola, the response is in months, not weeks. And so while Steve Martini, Director Martini and his staff has been preparing Motorola for what is coming, has been shared kind of the work that's been, the conversations that have been going on, we still anticipate it's from the point where we say, we all agree, yes, what you are proposing to us as the work to be done meets our needs, then that clock starts in terms of months. So again, we are talking in terms of months. The other piece of this, which is the police transport factor, is a similar integration in with the police records management system. And in speaking to John Singleton, who is the police IT director today, I asked the same question to him. There is no outside vendor involved. This, based on the directive that comes from this group or the policy that comes from this group and the understanding that we have in place today, he would scope it and he estimates a solution can be in place within a number of weeks. So it's a situation where you would have a partial solution to kind of your overall policy recommendation. You would have a solution to, in my estimation, to the police transport component far sooner than you would have it to the first responder to medical calls aspect.
So I'm just sort of thinking out loud here. And certainly anyone else push back if you feel differently about this. I feel that the concern of our citizens, our constituents, would be, while I have complete respect for the work that law enforcement does, I do know that there are some number of our community that have issues with that information being shared freely with law enforcement for fear of immigration status, whatever it might be. But I think that fear might be a bit lessened with the 911 responders. Would we be comfortable as a group communicating differently with the 911 emergency services operators if we found a solution to the police, Metro Police Department problem, which sounds like it's quicker? Just throwing that out there.
I mean, I want to just throw in my sense here. Is this policy, Dr. Campbell, with a group that we all agreed to serve on, put out? I mean, it seems like if I hear you right, David, you're proposing two separate things. One is approve this policy that, again, I believe the stakeholders we wanted to table were came up with. And then are you saying, which may take a few months to implement, if I understand that correctly, you're saying an interim plan in addition to that? Is that what I hear you saying?
Well, I'm just throwing it out there that if we found a solution for law enforcement that made it more secure, would we be comfortable sharing the information a bit more freely with the 911 operators, the emergency responders? That's sort of where I'm going with my thought.
Yeah, I'm sorry, but at the end of the day, at this group last month, identified some key stakeholders who felt to represent some interests pretty well, and this is what that group came up with. In my opinion, I'm sorry, Dave. My only hesitancy, and the board is the board, and I respect the decision of the group here. But my only hesitancy is we had a group of really thoughtful people who I think the group felt would be representative of some of the concerns, come up with this policy. And I would be a little hesitant to move one way or the other. But Dr. Campbell, I see your hand up.
Yeah, I just think what we're doing is confusing two things here. First of all, we need to approve the long-term policy. What's the best we can do? And that's going to take a while.
Right.
And I'd like to, that's what I'm proposing, that's our policy. The second thing is what do we do in the meantime, and how do we find some middle ground between nothing, which puts people like the outbreak at jail in the jail in the foreground. How do we find something in between until we can get this Motorola solution in place? I just think they're two separate things.
So you would like to see a motion, you'd like to see a vote on your long-term motion and then come back to this conversation if we want to have it? Okay, I will second Dr. Campbell's group's motion then.
Okay, so Dr. Campbell and then a second from Mr. Frederick, but that's still now discussion time. So we still floor is open for discussion. And Sinead, I see your hand up. I know Carol's got something to say as well.
Okay, a couple of questions that I just need more clarification on. Number one, the law enforcement, bullet point B, law enforcement only if vehicular transport is involved, jail, ER, and I think Derek mentioned mental health co-op also. Does that mean that they would have to be, and would that be like a voluntary? I know that it would probably occur for being in custody involuntary, but what about voluntary custody? So what I'm not clear on is, do the police ever transport to the ER voluntarily because EMS wasn't called? Do they transport to mental co-op voluntarily, or are those custody situations? I was wondering if you could clarify that, Dr. Campbell.
Well, my information came from Chief Swan about that, and as I understand it, the issue was not so much whether it was voluntarily or involuntary, but if it involved someone being put into a police vehicle to be transported to another facility, then situation, law enforcement could inquire about the COVID status of the individual. Otherwise, that would be a privileged communication. It is that situation where you put somebody in the jail and they don't have enough isolation rooms, and they don't know if the person's positive or not. It's hard to treat everybody as if they're positive, or you're taking somebody to the ER or a mental health facility, and they're in a tight and closed space. Is that a reasonable time for law enforcement to have access in a limited way to who's positive?
Okay, and you mentioned Chief Swan. I was wondering if someone from the Community Oversight Board offered perspective around that particular point.
Well, Melody did a great deal of talking about the importance of getting the trust of people in the community. And her position was she felt like most people feel it's a reasonable thing to be concerned about the health of first responders, 911 people, or if you're transporting someone to a facility where other people are involved who might be affected and are sort of innocent bystanders.
Ms. Franklin, this is Keith Durbin. Do know that Jill was on on that committee, and she was in agreement as well.
Okay, thank you. And then my last question is over D. There will be auditing by an independent committee, including community stakeholders, to assess how the data will be used. I was wondering if Dr. Campbell, if you can speak to the makeup of the audit, the independent committee, who is going to determine what community stakeholders are on that committee, when will it be decided? Or is that something that the board has a role in?
I would think that's a board decision.
Okay, all right. Thank you, I appreciate that.
Thank you. Carol?
Okay, I was under the impression that we voted last month. We were all in favor of Motorola except for the time frame. because that builds in the safeguards when we have the Motorola program in place. I thought that the committee was meeting to discuss how can we deal with this in the interim. Is that just a totally wrong assumption?
Yes. I would say you're with Stuart. I think the committee was there to figure out how do we go moving forward, period. So.
Okay, because I was thinking that it was pretty clear that we all wanted the going forward with Motorola, but we weren't willing to wait several months for that.
I think my understanding what the vote was and what the committee said was we were in agreement that we needed a group to come up with a policy. Mr. Durbin let us know that he didn't think it was to be appropriate for Motorola or whomever to work with until we had a policy. So this is a policy. If approved, this would be the policy that would then go to the process that Mr. Durbin.
Okay, so David, that's what I thought you were asking. What about in the interim? And who would be giving this information in the interim? So what are we going to do in the interim? I mean, this is kind of where we are.
You're on mute, David. You're on mute.
Yes, I am. That is the question I was asking, but I believe that Dr. Campbell, based on the input from his group, would like to decouple those two questions. So I am good with supporting this long-term solution and coming back and having a conversation about an interim solution if we need to.
Okay. Okay. Only catfish.
Just more conversation.
So there are two questions here. So I don't want to undermine the work that went with Dr. Campbell and then the committee of really dedicated people with this. There is still a motion that was seconded about this policy being approved for whenever that solution happens. And it sounds like there may be a need or desire for further thinking around the interim and how we do that. Is that a fair, am I gleaning that right from the group? So can we decouple the two, using someone else's words here, and there is still a motion and a second for this to be the long-term policy, which would then authorize Mr. Durbin and colleagues to move forward with that. Is that fair? And so one more discussion.
I just have one question for you, Tom. When this is made as a motion, do you believe the for example is enough, or should we say JLER mental health co-op? Because the mental health co-op is a big deal in terms of the numbers of people who get transported.
It is, and that's why I thought of it. I don't know that those are the only places, though.
So would the for example be sufficient, or how do we deal with that? I would probably stop where transportation is involved and see if the legal department has a better recommendation than that.
If that's a question to legal, I would propose, instead of saying, for example, if it doesn't stop at transportation, that the parenthetical read as including but not limited to. And then those three specifics would be descriptive of the types of transportation when the information would be shared.
Including but not limited to.
Yeah, I think that our concern there, or the belief, and someone correct me if I'm wrong, is if the person is being transported to some situation where they are going to be introduced into some other population where they could spread the virus should they be positive, that's when we want the police to know that there is a possibility that this could occur, I believe.
Yes, that was my understanding of the group.
Okay.
Thus, that was the recommendation from legal for including but not limited to, because I don't think we are all able to fathom all the possible locations where a person might be transported that could introduce them to other persons.
Okay. Any other discussion around this specific policy before we vote, and then we can have more dialogue about interim? All in favor?
So this motion is understood that the motion on the floor and the second is specifically for the long-term policy.
Yeah, for what is written right here and what the work of the committee put together. Yes, ma'am.
Okay.
Okay, thank you. So with the changes of including whatever you just said, Derek, all in favor of this, please show hand. Okay, thank you. And all right, unanimous there. Now, do you guys want to discuss interim plan? Can we discuss that or how we want to approach that?
We have to.
Sure, please discuss. Do we send it back to Dr. Campbell and your committee for coming up with an interim, or do we? Because that committee represented some great stakeholders, in my opinion, and the board's opinion previously, but I'm open up to discussion. Feel free.
I'm willing to send it back to the committee.
Yes, and I think the particular question I would like to be posed to the committee, and they can react to it as they see fit, is since there may be a quick solution for law enforcement, would there be an interim solution they would like to introduce for healthcare and emergency responders?
Okay, this is Keith Durbin. Can I say something?
Yes, sir.
So I might suggest that sending it back to the committee, it might be advisable to bring Steve Martini into that group as well, who can represent the system operations and how the processes work within his department, since that's really the key point that we're talking about here, the key system, owner system.
I'd like to second that, because one of the limitations in the group when we discussed this was it was pretty hard to understand how the data systems interconnected right now and how all that worked. It would be helpful to have some nuts and bolts understanding of how the system works and what we can do and what we can't do.
Well, Dr. Campbell, I think that you pretty much have the authority as chair of this committee to bring whomever you feel you need to, including the people who are currently on the committee, to develop a interim policy or interim plan for this. And honestly, let's say the interim plan could be nothing, right? The interim plan could be the status quo. So I think we need to make sure that's not off the table until the more permanent plan, which we will hopefully have a timeline, is developed. Does that sound like what the group desires? I mean, there doesn't need to be a vote about this per se. It's just,
I agree.
Okay.
I think that's a good.
Dr. Campbell, is that fair?
Fair enough.
All right, Ms. Franklin, yes.
I just have a quick question for Keith, and I want to get it in before we lose him. I'm wondering, thinking sort of broadly about the systems being interconnected on an IT level, is there any conversation regarding CARES dollars coming in to support the IT infrastructure for situations like this for the COVID response?
Oh, absolutely. You bet.
Okay, great. Thank you.
Good.
Okay. We're good? Thank you, Dr. Campbell, and the group for your work to this point, and we just want to do this right, so thank you for the diligence. All right. Mr. Diamond, can you go through the grants and so forth?
Sure. We do not have any applications this month, so I will move on to the grants and contracts. We had 6 grants and contracts that were included in your packet. There were no additions today. The first was an infectious disease affiliate contract with Vanderbilt for clinical training in our infectious disease programs. Item number 2 is a grant from Maddie's Fund for MAC, and I know I've stated this before, but we have donation funds at MAC, and we also have what comes in as donations, but they specify how the money needs to be spent, so we need to treat those as grants, and this is one of those cases. Item number 3 is our school-based dental program contract with the state for this current fiscal year, which began July 1. Item number 4 is with DentaQuest with the state, allowing us to bill for any dental services provided to their clients. Item number 5 is with the National Academy of Medicine, which allows us to access their database of information. And item number 6 is an extension of the Baby and Me Tobacco Free, which is part of our tobacco prevention grant. So I can entertain any questions. If there are none, this would need a motion to approve.
I have a sort of a broad question. Are all of these continuing grants, or is any of this new funding?
The Maddie's Fund for MAC is new. All of the others
Okay.
are
But
renewals.
that is, again, that's a designated, that's a designation that was made by the donors, correct?
Correct. And we have donation funds set up. So if somebody just wants to give MAC a sum of money, that can go into our donation fund. But when they specify if it needs to be used for certain purposes, then it becomes a grant. And we have to track how all those dollars are spent. I see Derek nodding, so I'm telling you correct.
Yeah, and are the grant requirements and reporting and all that fairly consistent with what we've done in the past, and the funding, there are no significant changes?
Correct.
Okay. I would move approval.
All right, is there a second?
Second.
All right, it's Carol, second.
And I have a question.
And then there is some further discussion, Ms. Essington.
Now, I just wonder if among the board members, if you all want and believe it's important to have all of the documentation about these grants. For a long time, we did not, as a board, have that much documentation in terms of the, I mean, certainly the explanation of the grant and the critical information, but we didn't have all of the information about the contract, et cetera, et cetera. And then in the mid-teens, that changed somewhat, and you may be remembering that. All of a sudden, because previous chair before myself had some understandable questions and concerns, and so we started getting all of this material. I just want to know if you all want to keep doing that. I kind of think that we could go back to having the basic information, but in terms of all of that data, do you want to keep it that way, or do you want to go back to a more condensed version, where we would have certainly a clear understanding, but I just don't know if all of us are reading all of that material, 141 pages.
David and then Sinead.
Yeah.
Yeah, I think, Carol, I think you're spot on with where I'm coming from. I would much prefer to see a little summary that answers the questions I just asked. Is this new money? Is this a new grant? Are there new requirements? Is there additional funding? Are there additional personnel? That's much more important to me. If it's a continuing grant and we've been doing business as usual, then I don't necessarily need to see all that back up. But others may feel differently.
I'm okay. I like the idea of the summary. I don't know if we need to see the grant in the board in the advanced packet, but I would love for the link to the SharePoint site to be available to us so we can see. We've talked about and we've asked questions and had robust discussion on some of the grants, even the recurring grants that have come through. So I still would like to have access to that, even though it may not appear in the board packet. It can appear as a link in the electronic board packet.
Jim, can you weigh in on that? Do you think it's a better one way or the other?
We try to provide what the board asked, and you're right, that was requested, but I don't think you need to see sample templates of invoices and everything else that comes along with every single state grant that we have, and we have so many of them. So I see your point, and we can work to provide maybe a compromise. I took a couple of notes from what you, Mr. Frederick, and Ms. Franklin all said. So I will work with Martha and with Brad and with Derek, I guess, on the next month's packet to make sure we give you the information that you need. And I understand what Mr. Frederick says about anything new probably needing a little bit more explanation or a little bit more detail, and we'll take that into consideration.
Thank you.
I have one question for Carol about the sort of institutional memory of the Fatherland grant fiasco that occurred before my time on the board. And I just wondered if you might remind people of that event and why there was so much concern about the detail following that.
Gosh, somehow we never get away from that, do we? The fatherhood grant was like, y'all chime in here, I think about 2014, and it just was, without going into detail, much of which I honestly don't remember, but it was, there was a lot of confusion and different narratives, and in the end, it was not clear as to some of the specifics. And so that led to, I'm not being particularly specific, but not because I don't want to, but I honestly don't remember all of the details. It just created such a concern about our grant process, and that the board might need to be more aware for a period of time of a much more detailed overview of the grants that are coming before us. And again, Jim, I'm going to go back to you. You've been here, Tom's been here. Can you add anything to Dr. Campbell's question that you think is really relevant?
Absolutely. And I think the way I'm thinking is when we have applications, that is where you're going to want the most detail, because we do the risk survey and evaluate what's going on. So when the board is voting to approve an application, I think that is at the point where you all would want the most detail and the most information. Once the contract comes in or the grant comes in, you've already seen what it's about and what we're agreeing to and how much it is. So I would think a reference back to the summary would probably be sufficient. Now, the last few months, we haven't really had any applications. We really haven't had any time to evaluate any grants or the like. So that's why I don't think we've had applications in the last 4 or 5 months. But I think that's the point where the board really needs as much information as possible.
All right, I got it. There's been a motion and a second to approve what you proposed or presented. So
I think we did approve it.
All in favor?
What are we
on these? We just got a motion and second, and you started deliberating.
Oh, I'm sorry.
So all in favor, please show hands again. All right, unanimous. Thank you.
Just because I'm losing my mind doesn't mean.
No, this is good. I'm welcome dialogue. And then next, I think moving forward, Mr. Diamond, I think the consensus was to proceed as Mr. Frederick, Ms. Etherington, Ms. Franklin, and crew.
It's a working process. We'll
if it
try.
Doesn't work for us next month, then we'll go back to the old way.
We'll try to find a way to make everyone happy. I'm still looking for that, but we'll do our best.
Fair enough. Thank you, sir. All right, Dr. Caldwell, reporter of the director.
Thank you. I would like to let you know that I reached out to Sheriff Hall and asked for assistance to augment our enforcement compliance program, and he provided us with a full-time staff person that he's detailed to the Department of Health. She started Monday. Her name is Katie Stone. She is also a lawyer, and she is getting oriented now, and look forward to providing you more detail about what her assignments will be. I know that she had listened in on the board meeting a little earlier. I don't see her listed now.
I think she still is. She's up here.
Oh, are you? Well, I did want her to introduce herself if she can get on. I don't see her there.
Can you all hear me?
Yes, we can.
Okay. Yeah, I somehow lost internet connectivity, so you can't see me on screen, but I also have my phone on. So, hi, I'm Katie Stone.
Yes, if you would just give a background of your experience with Metro, I really appreciate that. Thank you.
Yeah, sure. I've been with Metro for almost 16 years now total. I started out as a public defender, and I was a public defender under Rolf Alderman, and then moved over to Metro Legal, and I was at Metro Legal as a client advice attorney for the sheriff and that group and then did civil litigation as well. And because of when I met the sheriff, he asked me to come in-house for him after a certain time. So I've been at the sheriff's office a little less than 11 years now. So that's kind of my Metro background. I've been a Metro employee since we moved to Nashville. So that's me.
Well,
thank you, Katie.
Katie, thank you very much. And while we're very grateful that you're with your background and being a lawyer, we are certainly going to just be helping to augment some conversations with legal. But Derek will, of course, continue to be our main legal representative from Metro Legal. But Katie is going to help us more with enforcement issues. And since we're talking about enforcement and compliance, I've asked Mr. Hugh Atkins just to give a brief report on how he has been overseeing the mask law as well as order, as well as the other public health orders. So, Mr. Atkins, are you available?
Yes, I'm here. Yeah, we continue to receive lots of complaints over Hub Nashville about various things on the order, mainly masks, employees not wearing masks at different facilities. And I think when I added the two spreadsheets together in my head, I got around a little over 1,800 complaints we have responded to. As I mentioned before, they all get a telephone call from some temporary environmental health specialists that we have hired to reach out to them, counsel them on the complaint that we have, and send them the version of the current order that we are under. They also generate a list. They check the list every day when the new complaints come in. And if we get duplicate complaints on establishments, then they generate a daily list that our field staff go out and make field visits. And if the visit results in finding an establishment out of compliance, then we have the option then of issuing a citation, which we have begun to do. We've got a couple that have come in today. Actually, they emailed them to me while I was on here, but we're over 40 citations that we've issued. We have been out probably on 150, 160 duplicate complaints. And then, so we're finding, 3/4 of them in compliance when we get out there, which is a good thing. But we continue to respond to those. And as we write those citations, that generates a little bit more work for the staff and also our support at Metro Legal, Derek and his team, because each one of those citations then has to be prepared for a court appearance. And we have had 3 days in court, I think, so far. Another thing I got notice on during the meeting is the July 15th court date has been continued, I think, to the 23rd. So the staff that are involved in writing those citations spend a good deal of time prepping for court and sitting in court after those are issued. So this turns into quite a time-consuming endeavor to write these citations. We are working, as Dr. Caldwell said, we're glad to have Katie Stone on board. I had some discussions with the mayor's office over the past weekend about enforcement, and they are working on possibly a couple of different models to help us out with that, because the sheer volume of complaints that are coming in and being able to address them in any sort of reasonable time frame for it to be meaningful is just, and this is going to go on for a while. We're not going to magically be out of any of this COVID-19 response anytime soon. The mask ordinance, we are working closely with Metro Nashville Police Department because the mask ordinance on the citizens is quite a different thing to try to enforce than the mask ordinance on the employees at the establishments. If we get a complaint on the hub, which we've gotten, that somebody standing down on the corner of 4th and Broad doesn't have a mask on, by the time we get that complaint, it's just not practical to think that the health department can respond down there and maybe find that person. Also, just the sheer volume of them is just more than the team at Environmental Health can practically investigate. We were already stretched beyond our limit before the mask ordinance, the mandatory mask mandate went into effect. It is a great mandate. We need a national mask mandate, in my opinion. It is the simplest thing we can do to be effective in flattening the curve and getting us back to normal. So it is definitely an appropriate measure to have a mask measure. But it is not something that the health department can reasonably be expected to enforce. And I'll just leave it at that right there. That's about all I have, I guess.
Just a question. I don't know if this is a question or if it's more of just more conversational, but the majority of what I hear tends to be around more of the tourist kind of areas that where the issues that people seem to notice. And I hear some from other business owners who are abiding by the orders and feeling frustrated that they are following them. And this is more about the business as opposed to the individuals. And I know that we are limited in what we can do because so many of the things we might even issue might really be state documents that we're issuing. We may not have the ability to pull, say, a certificate of operation, that type of thing. So is this what you're working on with Metro right now? Because I think if we don't get some teeth into this and the business owners who may not be following the orders don't feel some pain, we may begin to see less compliance with other business owners who currently are trying to do the right thing.
Well, we are working on that with, I had a discussion over at OEM this morning with Katie and brought her up to date on where we were and looped in Dr. Caldwell because I had the initial discussion with the mayor's office yesterday afternoon about some solutions. However, I mean, it's just a mathematical thing. I mean, we've got a handful of environmental health specialists and we've got 40,000 businesses. You cannot expect 14 environmental health specialists to cover over 520 square miles. When the first order was issued, it was 1 page long. It closed the bars and reduced the restaurants to 50% capacity. When Dr. Caldwell indicated that environmental health could handle that, that was a reasonable expectation. But Order 7, which we are essentially under now, Order 9 is the Phase 2 modified, which is mostly Order 7, is 17 pages long and covers 40,000 businesses. And also, as far as teeth in enforcement, I agree with you. We need to have these people doing what they are supposed to be doing. But again, it needs to happen more in real time. By the time we get these complaints on the hub and address them, we don't know what conditions, and when those places are crowded, say on Saturday night, that's when the transmission is taking place, not Monday morning when people are available to go check on those. I went down to Broad myself Friday evening and closed 3 places. Followed up on 1 complaint on an establishment that we got a complaint that they were operating, and when I got there, they had big chains and a padlock on the door. I don't know why somebody called that in, but even though that didn't result in a closure, I was kicking around down there Friday night, running that down. Saturday night, and I think we included in the board packet, I made 42 texts, calls, emails to close another establishment, working with people in the field. That was 1 closure that I worked on from 7 o'clock July 4th in the evening to almost 11 o'clock. It just, that is the discussion that I'm having with the mayor's office. We've got to have more resources, and we don't patrol. We don't have the staff to patrol the county. We don't have people stationed on every corner down on Broad. It's impractical, but that stuff needs to be taken care of. There are people that are around doing that thing. I walked by them and had trouble parking my car for them while I was there. And that is a source of major frustration for me. They do need enforcement. It's just that I've been telling people for 3 months now that if you want real-time enforcement, it's not going to happen under the model we're doing right now.
Yeah, totally understand that, and I totally agree with you, because I actually, it was early in the evening on Saturday, but I did go downtown, just drove through and saw a large number of people who didn't seem to be following the orders, businesses that might or might not should have been open, but I also saw quite a large number of Metro police enforced down there. So they are on site. They know what is happening. So we need to engage Metro in helping us to enforce this, because I don't see how enforcement is the health department's arena.
Well, no other jurisdiction in the country is trying to do it the way we are. Now, I'm sure they're busy, but I keep a pretty close eye on that when I see stories in the news, and run them down to see who's issuing citations, taking enforcement action, and I usually find that it's not an environmental health specialist with a clipboard.
Hey, Hugh, can I add something?
Sure.
So, Mr. Frederick, there are very early on in this process, the legal department laid out a series of potential options, one of which is in active discussion. That's a very different approach than what we have tried so far. It would, if we can move that direction, it will look a little different, but I believe it will be effective, because we have to, we've got to stop this game of whack-a-mole that we play every weekend, and figure out some way to deal with just let's say the repeat offenders. And there is a way that can be done, and those conversations are underway, and I am hopeful that if we can pursue that course of action, it would have an effect on the behavior of the community. Thank you.
Is there anything that you need on behalf of this board to help you with that conversation, or do you feel like you have that conversation under control?
I don't feel like I have anything under control. But not at this point, I don't think, Mr. Frederick. Thank you.
I don't think so either.
It's a well laid out legal process. We have to just figure out how to effectuate it, basically.
Well, I very much appreciate all the efforts that you guys are going through, and I know that we are not set up to do enforcement, and Hugh especially, I appreciate your crew and the fact that you had to spend a significant amount of your 4th of July doing this, and that you did it because it's the right thing to do. But I would love to see us be able to do this more effectively and with less stress and strain on our staff.
Yeah, I agree 100%, and I appreciate this.
All right, Carol, you have something you want to say?
Well, no, I think David just said it. I wanted to ask you, Hugh, if you, thanks, Tom, for sharing that. Do you believe that there's some relief in sight in terms of an action plan coming?
Yes, I think so. I really do. This week, as I said, I've voiced my concerns over these issues for quite some time. I've voiced those concerns maybe a little more vehemently Saturday night to the mayor's office, and they are very supportive, and I've heard more feedback from them this week on trying to get a workable solution, because I have to be careful. Nobody wants these things enforced on any more than I do. So I don't want it to sound as if I'm against enforcement. That is not the case. I told Tom when he made me aware of the first couple, that we had 2 on Broad, but everything else looked pretty good. So I said, look, I'm going to get in my car and I'm going to get down there. If we can get a handle on these 2, and that's pretty much what we got down there, then we could make some real headway right now. So I got down there, and they were under management of the same company, and they actually even told me, we've got a 3rd place around the corner here we're operating, and I assume we shouldn't be doing that either, and we'll close it down too. So we got 3 for the price of 2 there, and then got the other one on Saturday night that was a different thing. But yes, I believe with the new order that came out at the end of last week and what went on this past weekend, we're finally making some headway in getting a solution to that.
All right, thank you. And I will say, I also echo everything, and I think you're right. The mayor's office understands the importance of really focusing this effort outside of health. So, thank you, Dr. Caldwell. Dr. Caldwell's still in the middle of his report. Go ahead, Tanae, and then we got to move on.
Just quick question. Can you just give us a sense of if bar owners or restaurant owners, if a case or a cluster is identified in their facility, of their willingness to do the right thing, maybe close on their own even before the 9th order was implemented? Just are there good actors out there that you could sort of highlight?
Yeah, I think, and that's a good question, because I think that's important. And it's easy to lose sight that I think in all the enforcement, most of the businesses are trying to do the right thing. That's what we've seen. That's what field staff reports back. But it's like anything else in any kind of compliance program you're running. You spend your time running down that other 5%. But you're right. I mean, even I think it is important to point out that when we've seen positive test results come in from employees that are reporting that they work at a particular establishment, when we've reached out to those businesses, they've been very forthcoming with employee rosters, timesheets that verify what times and dates those employees work there. They voluntarily closed for cleaning their establishments, many and much of the time longer than probably would be recommended by CDC, and they do it. The establishments we went to that I went to on Saturday night were under the impression that they could reorganize their operation and operate as a restaurant like some establishments did during Order 1. As soon as I explained it to them and showed them in the order why they couldn't do this time, there was no hesitation. They said, we do not want to be out of compliance with the order. We don't, and they immediately started having patrons leave, posted a sign saying we're closed. They even provided some distance between some unhappy tourists and some health department personnel that weren't happy that I was closing the place down. So we are getting, there's room for, again, I said the latest order is 17 pages long. There's room for misunderstanding in there. Now, most of the businesses, if you're running a business, I think you should know what the requirements are. But that was, that went into effect at midnight on Friday, and this was Friday afternoon evening. There was not a lot of education done about what Order 9 did. But yeah, I think overwhelmingly the businesses have been cooperative, especially even if we got an impression that they may not be taking the outbreak as seriously prior to it. When their employees start showing up positive, then they're ready to do whatever it takes to cooperate with the health department and help us get to a solution.
All right.
Thank you, Mr. Atkins. Thank you, Tom Sharp. As you can see, this issue of enforcement is one that certainly has a lot of interest and takes a lot of time. And also want to reinforce that in addition to us just trying to think through on our operations and executing those operations, once a business is cited, it then requires us to work more hours with lawyers to prepare for court and then more hours in court. And I, on Tuesday myself, because I was directly involved in more than one of these as the director, have assigned, sort of half of my day is assigned on Tuesday to be in court to address one of these specific citations. As well, there are other lawsuits that are being brought against the orders that require the time of me and the staff here in responding to those orders. So it is more than just us responding to a complaint. There's so many other elements to it. So thank you for that. And we will continue to keep you updated on the what we're doing for enforcement. Every time there's a new phase, there is a new complementary public health order that then requires a whole new education to the community and enforcement strategy. And adding the full mandate mask order to this now has challenged us, but I can tell you, I think we all have risen to the challenge, not only as a department, but as a Metro government. We still are trying to improve that. And more importantly, I think, Mr. Frederick, you did say it, and I think we all have seen, there is now, the mask order has passed, I think, at the right time. The community was ready to accept it, and we are seeing in certain parts of the county great increases in compliance. There are parts of the county where we're not seeing that, but I think we are moving in the right direction. So, Mr. Atkins, thank you for your continued leadership on this with us, and we're really glad that Katie Stone will help be a part of our teamwork. I do want to cover some other categorical areas. Please notice in your packet, at the request of Dr. Campbell, you do have overdose data now, which is in your monthly packet, and that will that's the overdose program. So please look at that. We'll be looking for your feedback on if you feel that's the right amount of information you're looking for, and that will be included in your packet monthly. Of course, we're really concerned about the continued increase in overdoses, not only deaths, but just overdoses in general. They seem, last year was our worst year ever. It was about twice as worse as the year before. And this year, on top of that, we're seeing probably a 30 to 40% increase overall. And it seems to have accelerated, of course, after some of the shutdowns. We really are watching this very closely, but our program is strong. I'm very impressed with how well it's funded, and the staffing of it continues to increase. So we have a wonderful program. We're going to have them on next month's agenda, possibly to provide a little more in-depth of the work that they're doing and some of the new tools that they have brought to the Nashville-Davidson area that are really exciting. You have probably been updated if you saw the news earlier that the Metro-Davidson schools will be not meeting initially in person. They'll be starting off remotely. That will not change, though, the requirements of immunizations. Still, they need to be enrolled, and they are required to be updated on their immunizations. So our team here at the department has been reinforced to handle the expected increase in demand for updates in immunizations. We know that a lot of children have deferred, been going to the doctors and getting their immunizations. So this is just across the country because of the pandemic. So we have ramped up our staffing in anticipation of a surge in needing to catch up with those immunizations for the children so that all of them can be ready at least to enroll as is required. The board members who have been with us for a while, that there's been a plan over many years to have a school nurse in every school, and there was a three-phase plan where we were hoping to achieve that goal over time. The first phase was implemented a few years ago, and phases 2 and 3 had been postponed due to budget concerns. I'm pleased to tell you that we've updated the nurse in every school plan and are getting the advocacy of school leader Dr. Battle to understand that with the goal of reopening schools in person, that having a nurse in every school really would be not only a nice to have, but almost a have to have right now. So we'll be seeing how that plan gets to be worked in concert with Dr. Battle's plan in reopening the schools in person. I don't have any more to let you know about right now, except that Lisa Nisler, who oversees our school nurse program, has been working very closely with the whole reopening schools committee, as well as this plan for providing a school nurse in every school. I've been providing you all one-to-one meetings in between our board meetings here, so I hope those have been satisfactory to you. I will ask Martha to make those one-to-one meetings with you between now and the next board meeting, as well as I've been providing you the weekly bulleted reports, which I hope you are finding satisfactory, and I will continue to get feedback from you between the meetings. There was one question that I had heard that there was, at the last meeting, one board member had asked about the police and how were they trained with face masks, and I do want to direct to you that I had answered that question in the weekly bulleted report, I think from June 12th. So if you could, or the 19th, if you could just double check that was answered, and if that was, if you'd like some more information, please let me know. One other program I wanted to highlight right now was our WIC program. You may know that has been acting sort of in a remote capacity up till now, and we have just recently learned that there's been approval for that to continue through August 31st. And we are actually, through this program, reaching more participants and eligible families than we ever have before, so it's working quite well. And so I'm pleased that the department and all of our other programs are continuing to operate as best as possible given some of the limitations that we have. One other issue is our distribution of face masks. You may have, well, for those of you who came to the department, you'll see that we do provide them here at Lentz in the parking lot every day from 9 to 3 p.m. And we also are really focusing much of our attention now on building our partnerships to have our partners distribute face masks to the community in ways that they think best, and so really pleased at that. So with that, Dr. Jahangir, I want to just conclude this brief update and look forward to continued conversations, and we're happy to answer any questions. We do have other colleagues at the department here that are prepared to answer any other specific questions you may have on any other program, so thank you.
Sure, so sorry, technical difficulty. Any questions from any of my colleagues? Okay, thank you, Dr. Caldwell. So the director's report, really, I just want to touch on a couple of things. One is, you may have heard our testing at our community assessment sites are continuing to grow. I don't know what the numbers are as of today, but by yesterday, end of business, we had 6,200 people tested at our 3 community assessment sites. I went to Nissan Stadium yesterday, and we did 1,000 tests roughly. Our colleagues at Meharry did 1,000 tests. We have augmented Nissan Stadium with 5 more tents, and the National Guard is helping under Meharry's direction to help get Nissan Stadium, our people in Nissan through. Dr. Wright, I know, has developed a team, his team of maybe have another team of mobile testing to get specifically in our areas that need it further, and there's some plans trying to maybe continue to do what we can to increase access to testing. But the work that we are doing is really amazing for providing a number of tests. I'm really grateful to our partners at Meharry Medical College for doing that. You guys have seen the volumes have gone up. I don't think I need to reiterate that that's obviously of concern. So far, the numbers are younger individuals, so our mortality rate still stays at 1%. There was a death of a 30-year-old gentleman over the weekend, which really has shaken me, maybe too strong a word, but it really upset me. So I think just realize that this virus, he's the first individual in the 24 to 34-year-old range that has died from this virus. And from everything I can tell from what I've heard, he was a pretty healthy gentleman prior, so that's scary. So, but with that being said, and I've said this before, if you are over 65 years old and you're a Davidson County resident and you contract COVID, there's a 10.5% chance, 10.5% probability you're going to die. So that is huge. And I think I just want to keep reiterating that point. Right now, we're seeing a lot of young people get infected, and thank goodness that leads to less mortality. Still doesn't lead to less morbidity. There's a lot of individuals in hospitals, as our hospital volumes have gone to 188 individuals in Nashville hospitals that currently have COVID. Hospital capacity is still around 20%. Dr. Caldwell and I, right before this meeting, went and toured the alternative care site, Nashville General, with Dr. Bullock, who is the chief medical officer out there, as well as Dr. Morgan McDonald, deputy commissioner of health. That site is ready. If heaven forbid we need it, and that's about 70 beds. But we don't need it yet. But we are. It's top of mind for me on a daily basis. If you want to know what I think about a lot, that's what I think about a lot. And Dr. McDonald and Dr. Bullock and all have been a great partners, and we talk all the time, almost daily. Hospital CEOs and other leaders in hospitals, we talk almost daily. So we're keeping an eye on it right now. It's not an issue at this moment, but don't think that's not being watched. And then finally, the one thing I want to bring up is the fact that obviously Dr. Johnson has rolled off the board, and the mayor is appointing Dr. Calvin Smith of Meharry Medical College. He will be hopefully confirmed by the council next council meeting, I believe, 2 Tuesdays from this last council meeting. Dr. Smith is a gentleman, and when he comes in, we'll let him formally introduce himself. But just give you a quick background. I graduated at Morehouse College, Meharry Medical College, and is now on the faculty of Meharry Medical College, and in fact is the assistant dean of admissions currently of the medical school. He's done a lot of different work in different areas, including food deserts and so forth. But I think what he currently at Meharry is also the person who is overseeing their COVID response and is a clinical site lead for the assessment centers at Meharry Medical College. And as I said, the assistant dean of admissions and associate clerkship director for internal medicine. So a true academic physician who's an internist who I've had an opportunity to speak to him a couple of times. Seems like he's going to be a wonderful addition to the board. And he may be listening in now. I invited him to listen in. I don't know with certainty if he has, but he did. He hopefully will be, and hopefully will, assuming the council approves him, will join us at our next board meeting. So that is a very quick synopsis of my report, but I too am open for questions if any of my colleagues would like to ask me anything. Okay.
Can I do a shout out for Tanae?
Yes, ma'am.
Okay, Tanae, thank you for participating in that Vanderbilt seminar, which was excellent. And for those of you who don't know it, it was structural racism in health and healthcare. And I just have so many colleagues who not only appreciated it, they sent it out to a whole bunch of students to watch. So thank you for that. Did a great job.
Thank you.
Yeah,
I was
it was a
in
wonderful
very good
panel.
company.
Yeah, you had good
So
company. You did a great job.
Dr. Consuelo Wilkins, when she says jump, you say how high. So I said how high. So thank you.
Yeah, I agree. I saw that as well.
Yeah.
I will say the review board request there is from our June 11th meeting, just for formality. We did review this. Okay. And is there anything we need for next month? Is there anything that I didn't remember that we need to ask Martha? Martha, what do you have?
We inform board as orders are being developed.
Yeah, so I will commit to, Dr. Caldwell and I'll commit to, if new orders are developing, to inform the board. Okay.
I also have one.
Oh, I'm going to have Tanae, then David, and there was a third voice. Is it Tom? Or somebody? Okay. So do it. Tanae, would you mind going first? And then...
Yeah, sure. Going back to Ms. Amy Richardson's presentation at the top of the call, I was wondering if we as a board can get an idea of how that feedback from community health workers is being acted upon. So who's involved? I know we have community outreach folks inside the department. Just would love to know how we're improving our process based on that solid feedback. And I've heard some of those concerns in other segments of the community, so I think that they're spot on. So just a review of how we're improving our processes with that feedback would be great.
Thank you. Mr. Frederick?
Yes, and I don't know if this belongs on this follow-up list, but I believe that our conversation about sharing of data, Dr. Campbell's group is going to reconvene and look at a potential interim plan. I believe that was what we decided. Is that correct?
Yes.
Okay. Okay.
And then we'll just, I guess I assume that the consensus is we'll wait a month and hear what that report is before we act on the interim. And then it would be good to know if that month is all that needed for Motorola to do the permanent. So I would just throw that out there. If it looks like the permanent may be much quicker than the interim, we should just consider that. So thank you. And then Mr. Sharp, last but definitely not least, sir.
I'll be quick. So I will tell you that the development of the orders is basically a 24-hour job for Derek and me, and mostly Derek. What is it exactly you want?
I think what I've heard is they want, again, they being my colleagues here, just, hey, we're going to do this order and this is why, or something like that, right? Is that what I'm hearing, David? So you're not surprised you don't read it through the news?
Yeah, I think it really is more that, and the one that caught me most off guard was, and I think this may have been initiated largely by the mayor's office, but prior to the closing down of the bars again and going back to stage 2, I received 2 or 3 different communications from bar owners who had somehow heard about this before I knew anything about it. And this was early in the day before that, the day before the actual conversation happened on the Thursday morning. So word's getting out, and it would just be good if we knew that so we can address it when we hear about it.
So
I would like to add to that, David. I also received it from other sources that was going to happen and didn't hear it from anyone in the department.
Well, I'll speak too. I wish I had known. I didn't know it either, so y'all got it before I did.
Yeah, feel free to tell us. I didn't know it either.
Hey, Dr. Caldwell, I would like to also just let you all know that I guess as the mayor is considering different options, he does reach out to different people and does share, and others in the mayor's office share a range of thoughts of what they're thinking. And I think you should understand that that's going to continue to happen to some degree. And I think as Tom and Mr. Atkins did say, that until the mayor makes the decision on what his decision will be, that it's hard for us to determine at what point should we share what with the board, because sometimes if the mayor's just kind of assessing a situation, this might get, you might hear some information, but so it's not even sometimes communicated to us what the mayor decision may be, and that's kind of when we get active to work with him to coalesce that. So while we will try to mitigate and minimize that, there will be times when you still may experience this.
But I would like to say that I realize that we have vested our authority in you to make those decisions, and I respect that the mayor is trying to do what he thinks is best for the community, and I don't say that I disagree with any of the decisions that he has made. I would like to say that I want to reserve our right as an independent body to know about decisions and not simply be following the lead of some other body. I feel a little bit out of place when people ask me about questions that are decisions that are emanating, at least on paper, from the Board of Health, no matter whether they originally come from. And the belief is that as a member of the Board of Health, I have somehow sanctioned that, and sometimes I don't even know it. And that's just a little uncomfortable.
All right, I too will make sure that as I hear things, we'll communicate a message received. I understand what you're saying. Thank you. Okay. Anything else? Hearing none, again, always a pleasure. Hopefully one day we can do this in person again, although it is nice to see greenery behind you today and all the other nice background. On that note, I adjourned this portion of the meeting and open the Civil Service Board. Mr. Diamond.
Yes, Dr. John Gear. The department is requesting an approval for extension of out-of-class pay for 2 of our employees. The first one is Allison Rokas in our WIC division. She's employed as a nutrition educator, but is working out of class as nutritionist 1. And the other is Shamika Tumblin, who is in our National Strong Babies program as a program specialist 3, but being paid out of class as a health manager 1. Both employees' 100 days of out of class pay will expire on July 28th. And Section 410 of our civil service rules state that we would need board approval for anything longer than that. So in case both of those, or either one or both, need to be extended beyond 7/28, we'll need approval from the board. So we would need a motion to approve unless there's any questions.
So move.
Motion for Ms. Etherington. Is there a second?
Second.
All right, second. Is there any discussion? All right, all in favor?
Aye.
Aye.
Great. Any opposition? Great. That carries. Thank you.
And finally, the personnel changes for June were included in the packet. These don't need a motion, but I'll be happy to discuss any questions if there are any.
Any questions, colleagues?
I just have one question that's not about this generally. Is it impossible for us to test employees within the health department? I mean, I read that we're sending them to assessment centers. I just wondered if there'd been any discussion about testing them in-house.
Dr. Wright, are you on? Could you answer that question, or Dr. Caldwell, or somebody?
We don't test anybody as far as the public goes.
Right.
And we don't do occupational medicine for our people. Everything would be done through our vendor for occupational medicine if there was an injury or that type of thing. So while we have the ability to, it creates a different level of liability for the department that I don't think that we should take on. And we have the assessment sites. That's where we send every other Metro department.
Okay.
Or the private physicians. So I think we should treat our employees the same way we treat any other Metro department.
Thank you.
Sure.
All right. Any other discussion? Hearing none, I adjourn this. Thank you all. See you next time.
Thank you.
Thank you, everyone.
This has been a service of the Metro Nashville Network. If you would like to see this presentation again, or for more information about this and other programs, visit nashville.org.